This week on the BackTable Podcast.
If you had a case where there was a complication, it's already on your radar, you already feel bad about that, and you're already probably trying to think about things that you could have done better, right? And then to get some kind of communication, like this group of unknown individuals sat down and pulled apart your case on the medical record, and we determined, based on our potentially lack of expertise in your discipline, that you had unacceptable care. I mean, how is that going to make anything better? I mean, even if it was unacceptable, it's not really going to change anything.
Hello, everyone, and welcome to the BackTable OBGYN Podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com.
It's Amy Park. I'm here as the solo host of BackTable OBGYN tonight. Unfortunately, my co-host, Mark Hoffman, could not make it tonight. And I am so pleased to welcome back Maggie Mueller, who I've known since she was a fellow, which was a while ago now. And just for our listeners who do not know Dr. Mueller, she's an internationally recognized urogynecologist and reconstructive pelvic surgeon with expertise in minimally invasive and robotic gynecologic surgical techniques. She's pioneered the single-port robotic surgery program, as well as cares for adolescents and young women with congenital anomalies, such as Mayer-Rokitansky-Kuster-Hauser syndrome, and has an ABOG focus of practice designation in pediatric and adolescent gynecology. She's been involved in multiple high-quality studies in terms of NIH-funded research, multi-center trials, has widely published, and is also passionate about surgical education and is involved on many national and international societies in multiple levels, developing curricula, redesigning milestones, teaching courses and nationally and internationally in surgical techniques. But today we are going to be talking about peer review, which I was very surprised to hear that was going to be our topic. So I cannot wait to hear more. So welcome tonight, Maggie. Tell me how you got involved in peer review and what's the process been like?
Thanks, Amy. Well, thanks for that introduction. And I have to say that when I was asked to talk about peer review, I was actually kind of surprised too, because I feel like it's kind of like that dirty little secret that's always kind of behind the scenes that no one really talks about. So I was really happy to hear that's what we were going to focus on today. And so I guess I can tell you a little bit about how I got involved. And I guess it's true. I don't think I knew much about peer review before I got involved in peer review. I knew that it was something in the background. I'd heard about it. I honestly don't think I ever heard about it in a positive light. Usually somebody was grumbling about peer review, but it's actually very important. So I got involved with that several years ago when I had gotten into the space of wellness and well-being. I had, had a couple conversations with some OBGYNs about this very negative experience that they'd had with our peer review committee. And that prompted me, I'm a curious person, that prompted me to kind of investigate a little bit further, to peel back that kind of, I guess, if you will, screen a little bit to see if I could figure out what was going on. And once I got a good handle on things and, spent a lot of time talking to folks about their experiences, I actually started working with the CMO to make some changes. And I think ultimately it was viewed as fairly favorable. So I guess that's my long kind of introduction into the topic.
Can you explain the importance of the peer review process in OBGYN, but just generally speaking, because you alluded to it, but why, is it punitive? Is it a good thing? What's exactly going on here?
Well, I think that it's typically viewed as punitive, and that's what I had heard before, but it's absolutely necessary. So hospitals, by law, to be insured by certain major carriers, they have to have peer review practices in place. So this dates back to like the 70s or something. So it's definitely been in place for a long time, but the degree to which a department or a hospital practices peer review certainly can differ just between departments and institutions or hospitals, and very widely throughout hospitals in general. But in its simplest form, it just means a peer is reviewing a case, and typically there's a reason for that review. So a trigger has gone off, you had an EBL that was greater than some arbitrary value, which, triggered this process. So it is important because it keeps us all, reliable and accountable to moving things in, an appropriate direction. I think a lot of people think about it like almost like quality assurance. And as being a division chief, we're always trying to move from quality assurance to quality improvement. And I think that peer review has kind of lagged behind a little bit. And what I mean by that is really, I think that most people viewed their capacity as, ensuring that there was quality, so that quality assurance, but not really moving the mark on making things better. So typically in a general peer review system, you'd have a committee that's made of, in the best case scenario, multiple kind of multidisciplinary peers. So providers, if they're surgeons, medical doctors, mid-level providers like APPs, and then usually nursing representation that would review cases that are either brought forward via a referral, so a peer referral, or via the trigger, of some outcome. And then those cases are reviewed, and then there's an arbitrary kind of grade, if you will, made. And I think that's where this idea of quality assurance comes in versus quality improvement. So you can give someone a grade and say, okay, this is fine. It could have been better, or we really disagree with your management. And then, you check a box and you move on. And that may or may not get communicated to a person. Whereas in a quality improvement capacity, you would want some kind of actionable outcomes coming out from that peer review. So I think among other things that I worked on, kind of converting that from a quality assurance to a quality improvement process was kind of one of the big hitters.
I love that. I think that's super important. When a hospital gets acquired by Cleveland Clinic, it plugs into the quality and safety rubric and framework and, the institute model and all sorts of stuff. And I know one of the things they emphasize is a just culture, but I think it so easily can veer into, I don't want to say vindictive or unjust or what have you, but it can, as you alluded to, it can feel a little punitive, because I do have colleagues who say, I did everything right. I saw her once during her pregnancy. This patient happened to have a poor obstetric outcome. And then, this process kind of happened. And it's, I think there's a lot of just questioning how the process works and who is represented on the committee and how these grades are assessed. Can you shed a little bit of light on that?
Yeah. I mean, again, I think it's different from every institution. I can tell you that feeling is definitely mutual. So everyone as I'll be to back up. So I started to view this through a well-being lens. And the reason why, there were multiple OBGYNs that when surveyed said that, this was a terrible experience going through a review process like this. They're, if they had been through this peer review process in the past year, they were, 3 times more likely to contemplate leaving medicine. And I think that they met all the criteria for burnout, the loss of control aspects, the fact that there was really no transparency, the fact that it was communicated, kind of more in a punitive manner. The members of the committee were anonymous, and that's usually like a red flag for if you really want something to be anonymous, like there might be a reason for the reason that you don't want to put your name down. So I think that there was a lot to work on in the prior state. So I guess I think I underestimated the, it sounds like a peer review, like no big deal, like check the box, whatever. But I really underestimated the effect that a process like that could have on a person. It's almost akin to going through, a litigation or any kind of review process where you feel like this is going to be punitive, you feel like it's out of your control, et cetera. So I think, some of the best practices that I learned in kind of revamping, if you will, this peer review process is, I mean, you want to be transparent up front. So you want people to know that there is a role for peer review. Peer review exists at this hospital, and we do it, for the reasons of improving outcomes and, identifying educational opportunities, and then involve them in the process. So it should not be this shroud of anonymity that's, keeping everybody separate. I think that one of the things that we did, which was actually a very large battle initially to get people comfortable with the idea that there would be that loss of anonymity between the reviewers and the provider. We actually had the peer reviewers speak with the person who had a case being reviewed, number one, to kind of demystify that. But number two, I mean, it's really hard, as you know, and, just as you reference with the obstetric provider, it's so easy to Monday morning cornerback and look through the chart and say okay, well, I think that it happened because of this, but you don't really know what was going on. If you sit down and talk to the person and you find out that, they were working for 48 hours and the person who was supposed to be on the shift with them called in sick and they never really planned on taking care of this patient, but it just wound up that they had to take care of this patient. And then they found out that there was no nurse or something like that. There's all these extenuating factors that can come into play. We actually started looking at those external factors and would kind of categorize the things that we identified from the reviews from the chart and in speaking to the provider as kind of individual factors versus kind of institutional factors or operational challenges, things like that. So I think a lot of people are starting to learn to incorporate that type of model, just, in M&M, things like that. You might see those fishbone analyses that are presented. It's really not, Amy Park had a bad day in the OR and something went awry with a case. Usually there's 20 other things that are happening and contributed to that case that were, largely potentially out of your control. And I think that's where we really started to focus on kind of moving the needle and involving the provider.
I definitely hear what you're saying because, having the wellness lens, which I love the wellness lens, and I love the way you put it, quality assurance, which is like a check mark to a quality improvement lens. And how can we utilize it? Because there's all those human factors that go into it. I love the human factor research as well. And so let me just ask you, when you've gone through this journey, and I have to commend that this is such a heavy lift to change the culture around this, what have you gleaned as best practices to make it a better experience for everybody involved? I mean, you said you're looking at individual factors, organizational factors, recommendations for improvement. Did you lead the committee or were you as consultant? How did you end up making it into a better process for everyone?
So I was lucky when I kind of hit the scene because the CMO at that time of the institution was actually really interested in this and interested in changing it. They had identified that this maybe wasn't a great setup. So our former setup, it was anonymous. You never actually spoke to the doctor or the provider. You really had no communication. There were a bunch of random arbitrary factors that ranged from, an unanticipated ICU admission to a DVT post-op. So just a huge kind of, smorgasbord, if you will. There were differences between surgical specialties about what was a trigger for one surgical specialty versus the other. And then that quality assurance piece. So they gave you the grades that you were given were acceptable, questionable, and unacceptable.
Oh, well, so that's not very much of a range.
Right. So there was really, so what do you get that back? And, a case that you probably were already really stressed about, we're all good doctors. We're all there's not a person that's going out to intentionally do a bad job, right? We all come to work and we're trying to do a good job. So if you had a case where there was a complication, it's already on your radar. You already feel bad about that. And you're already probably trying to think about things that you could have done better, right? And then to get, some kind of communication. Like we sat down, this group of unknown individuals sat down and, pulled apart your case on the medical record. And we determined, based on our potentially lack of expertise in your discipline, that you had unacceptable care. I mean, how is that going to make anything better? I mean, even if it was unacceptable, it's not really going to change anything. So one of the things that we had done, in this whole revamp system is, as I mentioned, we got rid of the anonymity. I, along with one of my colleagues, created structured videos on how to debrief, like how a reviewer could debrief with the provider. And we use the AHRQ format for basically just doing a verbal or in-person debrief to get information and their point of view for what happened with the case, et cetera. And then made those, publicly available to the different reviewers. And then we categorize those factors, so individual factors and then other circumstances like system factors. And there's a whole bunch of things that can fall into system factors. And then for the quality piece, anything that got triggered by a system factor from either a GYN case or an obstetric case or a general medicine case would then go back to that quality committee as, we identified that this was a potential quality concern. It could be like, we noticed that this patient got fluid overloaded and, for 4 days, there was no documentation of ins and outs from the nursing team or something like that. And then that quality team would work that out and to come up with a plan to avoid that from happening. So it did really kind of help identify other quality like systems aspects. And then when there were individual factors that contributed to an outcome, instead of saying this was unacceptable or acceptable or, questionable care, we came out with kind of a structured algorithm for what could the provider do. So many times they were like, we reviewed this case and there was absolute appropriate care. We have nothing to add. Or we reviewed this case and, I think that there were some opportunities. So there could be, this is called like a learnings letter, if you will, and just kind of outlined, there are a couple of things that we think, you might benefit from, whether it's a structured simulation or something like that. And then different kind of graded levels of different outcomes. And I think that it took away this very punitive, you got this score, we're going to send it to the MSO in your chair, versus, we identified this as a hard case. There are a couple of things that we think, might have contributed, and here's what we think you can look at.
Oh, it's I agree with you. Like, this is such a second victims thing going on, because it's like, not only, I know when I have a complication, like all of a sudden it's referred to M&M and then you're getting, assessed by the quality and safety folks and they assess you this grade. And it's like, this patient hasn't even rolled out of the hospital yet. Like, it's like, it can be very horrible on your sleep and, depression. And I mean, now I've been out almost 15 years, but it still hurts. It's like really painful. And what makes people want to quit when they're early in their career. And like, we need people to like keep on going, keep on doing that. I mean, we don't have enough of us. So we need to do the improvement and the work to support our people, because that's the whole point. Well, I know for us, we have, when you first join as staff, there's like a focused, I can't remember what it's called.
The
practice.
FPE.
Yeah, FPPE.
Performance evaluation. Focus, practice, performance evaluation.
Right, the FPPE. And I think it's for the first 6 months. Usually people sail through it or whatever. And then it's assessed occasionally when there might be concerns. Can you talk about that? Like, have you ever been involved in that kind of process?
Yeah, absolutely. And you're totally right. So there's, FPPE and then there's OPPE, or ongoing performance practice evaluations. And that's probably, you probably have it for your division where you get, some document that says this is your annual OPPE and you have
peer evals. Yeah.
Yeah.
We just had to do that, actually.
Right.
I had to bug one of my partners, like, I'd like to keep on practicing here. Can you sign up? Can you do this like online form that takes like 1 minute?
Yeah. And some of them even have statistics, like your rate of third and fourth degrees are XYZ and, your length of stay is this. So every hospital and discipline can do it differently. And then there's, a focus performance practice evaluation, which can be not the initial one, but we've identified an issue. So let's say, you're my division chief and I've just had a run of either really bad luck or you're starting to wonder, Maggie, what's going on in your robotic surgery? I notice all your EBLs are greater than a liter, and this is, really unusual. And so that focus practice, performance evaluation can take a couple different forms. So you can say, I think you need to be proctored for 10 cases. So we're going to bring someone in, they're going to proctor you. Or we're going to need to review a sample of your cases, like please submit your next 10 cases. Or before you schedule another robot procedure, we need to make sure that you go to the simulation lab and you get XYZ mark in whatever outcome that you want to have. So it can really be whatever you want it to be, but it basically is something that is tracked by the medical staff office, that if you're saying someone is on an FPPE, those things actually need to happen, as a, basically a practice improvement opportunity.
Like, when do these grades, do they make it into your file, so to speak, your personnel file? Or like when does it trigger that file process? I have no idea.
Yeah. And again, that can differ by institution. So I can tell you in my previous work, so that 3, you did something that was unacceptable, or we decided was unacceptable. That went to the medical staff office, and then that was kind of like in a permanent file. But you could make it that all of your, like in your ongoing performance practice evaluation, you as a division chief could say, I think it's really good for me to know how many times your cases have been to peer review and what the outcomes were, and that'll go in the file. I think it's a little bit of a slippery slope, because anything that time you're trying to put something on paper and make it look like it's a metric, people get really twitchy about that. And I would say that unless there is some serious problem, I would advocate very strongly to keep that out of a file, if you will, or medical staff office, because I do think that it undermines the process, that we're trying to really improve quality care. We're trying to identify educational opportunities and performance opportunities. And once it gets written down, or it feels to someone that it's being documented in a way that potentially could harm them, it's kind of viewed as that punitive method.
What, if any, do the SIRS reports play in this process? It's like SIRS, to me, it's like also in the spirit of quality improvement, but it's for us, it's called SIRS. It's a serious event reporting system, but it can feel like weaponized complaining.
Yeah. So I feel very strongly about this. So I do think that is a very good example of the ways in which we have weaponized a patient event reporting system. So, there's actually a good amount of research. We've heard about some of this research at OGS and SGS and things like that, where many of these kind of interpersonal communication complaints get logged as safety complaints, patient safety complaints, which I understand that if you have a terrible, toxic working environment, that could affect patient safety. Obviously, if somebody doesn't feel like they're able to talk up or speak up, or they feel like they, every time they do something, they're going to make a mistake and be criticized for it. Yes, obviously, very bad. But the sad truth is that there is a disproportionate amount of women and underrepresented minority where there are folks that have lodged these kind of minor interpersonal communication complaints on their behalf. So I do think that is something very different and should not be a part of peer review. We should draw a line in the sand. Someone in a position of power at an institution should be reviewing those kind of complaints and determining if action should happen, but with a very, very large grain of salt, understanding and identifying that there is inherent bias in those reporting systems, and we should be really careful.
I agree. There's lots of research like you're alluding to, and it can be just a lot of microaggressions kind of coming through the patient reporting systems, and certain people just get them lodged all the time. And sometimes it's deserved, but sometimes it can be just really feel like it's not conducive to improvement. Well, so let me just ask you also, how does a peer review process handle discrepancies or disagreements among reviewers? I mean, I assume it's a committee. How do you even be qualified? I mean, it sounds like you instituted some best practices in terms of like structured assessments, but can you like delve into how this is all?
Yeah, I mean, I think the best committees are multidisciplinary. So they really should have representation of every surgical or whatever type of specialty is you're reviewing. So if you have, like a hospital-wide committee, you should have representation of all the different medicine subsets, GI, cardiovascular, et cetera, and surgical subsets, because it's not really easy for someone without the content expertise to determine whether or not this case there was an issue or not. Now, a lot of times people will run into the fact that in like much smaller specialties like neurosurgery, that maybe they can't really always have representation because maybe they really only have one neurosurgeon and that person can sit on the committee, but then when there's a neurosurgery case, it might be theirs and they can't really review those. So those are the times where external reviews can be helpful and keep a little bit of a non-biased but still content expert in the mix. Certainly, I think it takes some time to educate peer reviewers, and we created a lot of different materials to educate people. They have to understand the ground rules, understand what we're trying to do with peer review, that it is not punitive, that it is important, and there's a reason for it. And, the reason is to better the care that patients are receiving at this hospital. They should know, that they need to check their biases at the door, that they can't always get all information from the medical record, and they really have to be comfortable speaking to someone about what happened in a certain case. Now, that's an art, and I think that that's probably the hardest thing to teach, because I don't think that, throughout our medical education, we really learned how to do that very well. I think there are some we can copy from bits and pieces like simulation. People have gotten really good about debriefing about simulation. And I think maybe that's where people can kind of come back and, find a little bit of their comfort zone if they learned how to debrief with a team in a simulation exercise. This is really not very different. And we created a little algorithm for everybody to go by. But still, I think that's probably one of the more nerve-wracking aspects of being a peer reviewer. But I think that you just have people that are passionate about quality improvement. Oftentimes, these are the quality leads of different specialties that are reviewing cases. They inherently know what the role is, and really that multidisciplinary, non-biased participation.
How does a peer review process in OBGYN differ from other medical specialties? You alluded to that a little bit. I mean, the content expertise, but the obstetrics in particular, I mean, GYN surgery is surgery, I feel like, but the labor and delivery is like a pretty tough place.
Yeah, I think you kind of hit the nail on the head. I do think that, most of the GYN surgical disciplines really do fall. I mean, they could just be in a regular surgical peer review committee because the triggers should be the same.
Yeah.
EDL,
right, like the visceral injury, takes backs,
kind of the same.
Yeah.
But then obstetrics is where it gets really confusing. And I think that some of the things that I've seen that are really helpful is having really good neonatal or pediatric intensivist representation, because they kind of can tie in everything together, from the maternal outcomes and the baby outcomes. So having one without the other is really not ideal. Having nurses, midwives, any kind of APN or PA that might be providing the care, you would definitely want them to be represented on the peer review committee. And again, I can't really underscore the importance of actually talking to the provider, because especially in obstetrics. There are so many things that go into the factor of making these crazy decisions about when to do what, and consults, delivering somebody, Pitocin, like all of those things are just, making every little decision. And then the aspect of shift work. So like I inherited this patient because they've been laboring a VBAC times 2 all day. And so then I felt pressure to continue on with this plan of care. I mean, it's just so complicated. So that actual one-on-one conversation with the provider, and probably any provider that was actually in that case, is going to be really helpful for identifying, factors that contributed to one outcome or another.
Yeah, I feel like the OB is like a very particular, a very high, there's also all this liability associated with it, and 2 patients, the mom and the baby. So it can, and, it's just very multidisciplinary in and of itself. So I hear what you're saying about having knowledgeable stakeholders and people who are involved in the process and involved in the peer review, because it is part of the quality and safety rubric. And it is interesting that you alluded to SIM, because a lot of the simulation people ended up in quality and safety, and a lot of the simulation people are no longer doing SIM. And I've just noticed that I've seen the arc of that, all happening, because simulation was supposed to be a means to bridge the gap in gynecologic surgical technique and knowledge. And it's interesting to see how they've kind of like moved over, which is a whole nother podcast in and of itself.
Oh my gosh, yeah. You did mention one thing, like the medical legal aspects, and I think that that's another part that people don't necessarily always understand. So once a peer review process is triggered, by whomever triggers that, whether it's a nurse, quality leader, etc., everything is protected. Like in our state, it's protected by the Illinois Medical Studies Act. So there's, this is protected information. It's not like the committee could be subpoenaed and the outcome could be identified and used in court or something like that. So it is a protected activity, and the outcome of all these things, it remains protected. So people should know that this cannot come back and hurt them, even if a case goes toward litigation.
Okay, that's really good to know. I kind of knew that, but I didn't really know that because I've never really been involved in peer review myself. So I think it's really good that you are sort of unmasking this whole process, because it does seem very opaque and, like you said, non-transparent. Well, can you discuss some of the ethical considerations involved in the peer review process?
Sure. I mean, I think there's a lot of ethical considerations. So in the very beginning, we discussed that most of us come to work to do a great job every day, and most of us are not trying to do anything bad. But obviously, everybody's heard about some bad players, and there could be impaired physicians, and you can be impaired in many different ways, shape, or form. So I think that that's probably one of the ethical, considerations that we really, it is, among our best interest, everybody's best interest, to identify if those things are going on. And that is one area where the recommendations could be communicated outside of the peer review process, but involve other, like the physician assistance program and things like that. So that would be kind of the biggie right there. Bringing it back to the wellness aspect, many places, I'm sure that the Cleveland Clinic has a peer support program. And we think of supporting people during these, times where they've had acute stress, like a bad baby or something like that. But knowing that the effects of that, suboptimal outcome, when there's this kind of repeated exposure to trauma, like going through M&M, doing a peer review, getting called by a law firm that, they're going to ask for records, things like that. I do really think that we should extend the peer support to those scenarios. And there's a lot of good data that even if there's really good physician assistance programs in place, the likelihood of a physician calling a number and trying to get some mental health support, for something they're dealing with is is really low. But speaking to one of like a peer who could support them and also be protected within these guidelines, that's really helpful. So I actually got involved with a lot of the peer support for litigation and things like that, mainly because when I spoke to some of the lawyers, they noticed that they were like armchair therapists or, midday bartenders for people that were really struggling with going through some of these depositions and things like that, because that's another process where it's fully out of your control. You don't really know what the timeline is. They're hugely stressors. You start thinking about ways in which this can ruin your career. And the very first thing that the lawyer tells you is, so you're going to get sued, but so definitely don't speak to anyone about the case. So then you feel isolated again, like I can't even talk to anyone about this. And a lot of these individuals really suffer tremendously and go through a tremendous amount of support. There's actually some podcasts that actually delve into this a lot if you're ever interested in kind of hearing a little bit about that. But it's really concerning. So I think it is an ethical consideration for us to be willing to support people that are going through a process and support people in a way that, everybody is free from, getting subpoenaed and things like that, so that there's some protected activities during this type of support.
Oh, yeah. I remember two of my co-residents, they were on and this mom died. Turns out she died of an amniotic fluid embolism, but I mean, it was almost 20 years ago and it was not cool. The two of them suffered. They were grilled. They were just residents. It was crazy. Like, I mean, I don't know. I look back on that and I think about that. But I think, I remember Angela Chowdhury set up something great at Northwestern. My friend does it at Beth Israel. It is so important. We have a peer support here at the clinic as well. It just really helps to hear that people have gone through it. I've seen it on Facebook groups. So, I mean, it's just like you feel like persecuted and you're the only one who's gone through this when, in fact, many of us have gone through this. So
yeah,
it's unfortunate.
I think, and that's the other unique thing about OBGYN, there are some specialties that can say like, yeah, the likelihood of, ever getting involved in a malpractice lawsuit is so low, but it's not really low in OBGYN. It's actually quite high that you would be involved in some aspect, whether it's just having records requested, getting deposed, being a subsequent treating physician. All of these things can be really concerning, let alone if you're named in a lawsuit. I mean, I think it's really one of the aspects that we probably don't provide our trainees on a lot of, education. And I think we can probably do better knowing that our field is so highly litigated. I think the number from ACAG is like 74% of OBGYN providers will, be involved in some sort of malpractice proceedings. I mean, it's just really staggering.
Yeah, that is staggering. I didn't realize it was so high.
Very high.
Yeah.
I mean, it's not that you're named in a lawsuit, but you've had some kind of touch, if you will, with the medical legal system.
Well, what can you tell us? What do you think are some future trends or changes you foresee in the peer review process?
Well, I think you mentioned one of them. So the just culture algorithm has certainly taken a hold and started to kind of seep into lots of hospital systems. And I think that I do think that that's protective and helpful. And again, it's trying to move away from this punitive identity that peer review has had for a long time, identifying that, in that just culture algorithm really, although it talks about deviations and things like that, it really was the person working within his or his guidelines. Did they intentionally deviate? Probably that's not very many of us that are intentionally deviating to cause a poor outcome. So I think that that's very protective for, the physician workforce, especially within OBGYN. So I think as that kind of continues to percolate through a lot of institutions, that will probably have some positive impact on peer review. I also think it takes a while to convert from that quality assurance to quality improvement. But once people see, outcomes that are happening that are more related to the quality improvement, you start to see really great benefits. Most people want to jump onto that. So I do think that we'll probably see a greater shift in just kind of moving in that quality improvement direction. And then what I hope is that there's just going to be way more transparency about some of these things that were oftentimes happening behind doors, or they weren't completely well understood, or there weren't practices and processes that were really written in place. I'd love to see more physicians taking leadership and, really thinking thoughtfully about what an appropriate program would be, for them, for their colleagues, for their institutions. So I think a lot of, I'm always on the side for physician empowerment in terms of leadership and making sure that, we're the ones sitting at the table, changing these processes and, making them beneficial for not just ourselves, but ultimately our patients that we care for.
Absolutely. I think that's the keeping the patient at the front and center and realizing that this process, if it's not a just process, it harms patient care.
Totally. Absolutely.
Like we have to keep that in mind. And I think just like anything else, aligning physician, patients, our team members, nurse midwives, PAs and Ps, nurses, super important to have everybody on the same page. Well, thank you so much, Maggie, for all of your insights. And I really admire that you took this on, in your previous place and here at your current institution, because I think it's resulted in better care for everybody and caring for ourselves. So I appreciate all that you have shared with us today. And hopefully we'll have you back for another podcast on something else, because you always have great insights.
No, well, thank you so much. I was just so happy and excited to talk about, something that we don't really talk about very much. And, the last thing I wanted to say is that if everybody starts talking about the processes, we could probably make them, substantially better everywhere, because I think it's one of those things that you really don't know about until you start talking to people. Kind of like prolapse and incontinence. Pelvic floor disorders.
Exactly. Well, thank you. Thank you.
Thanks, Amy.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and Digital Marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Overjinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham. Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.